I am Dr. Saeed Nabeel Muzaffar, Associate Professor in Department of Critical Care Medicine, KGMU Lucknow. And today I will be speaking on the topic acute respiratory failure in haematological malignancies and the ventilatory strategies. In the next few minutes, we would be discussing about the epidemiology of this problem, the etiology and approach to diagnosis and management, the different strategies for ventilation, and the outcome of the patient. Now, beginning with the case scenario, a 58 years old male patient without any comorbidities, resident of Eastern UP, gets diagnosed with acute myeloid leukemia in May 2021 this year, after a 1-month history of fever, weight loss, and fatigue, labs showing pancytopenia. He was started with induction chemotherapy around 45 days after the diagnosis. And now he has come with fever and respiratory distress 2 weeks after the initiation of chemotherapy. And we get a call from the ward that the patient is in distress, and on assessment we find him to be agitated, tachypneic, and tachycardic. So this is a scenario most of us would have been facing. And the question is, how do we manage this patient? So seeing the epidemiology of the problem, acute respiratory failure is most commonly seen in acute myeloid leukemias and has an incidence as high as 80%, around 60% require ICU admission, mortality around 45%. Followed by stem cell transplant patients and MDS, the incidence is around 30%, and around 50% of the patients of stem cell transplant require ICU admission, and the mortality is around 50 to 55%. So the acute respiratory failure is a problem that is more common in myeloid leukemia as compared to the lymphoid leukemias. Now coming to the etiology. Etiology, as we know that the differentials of acute respiratory failure in immunocompromised or non-immunocompromised population can be very broad. So we need to have a systematic approach. A systematic approach that can be simple and easy to follow could be a head-to-toe assessment that we do in most of our cases. Beginning from head, we can have an increased respiratory drive at the level of the respiratory center, as seen in metabolic acidosis. Then at the level of the trachea, there can be an airway obstruction because of the tumor mass, intrinsic or extrinsic, that we need to be careful about while intubating the patient. If the patient is in stridor, then it can give us a clue about the tracheal mass. For them, most importantly, the thoracic cavity, where we have the lung parenchyma, vessels, pleura, and the chest wall. The diseases of the lung parenchyma can be categorized into infectious and non-infectious causes, and that we'll discuss subsequently. And the vascular causes could be related to pulmonary embolism from thrombus or the tumor, or the pulmonary veno-occlusive disease here in stem cell transplant patients. Then we can have the patient could be having large effusions related to malignancy, pneumothorax, hemothorax, and rib fractures that we need to assess in our patients. So what could be the clues to our approach? It could be the clinical and radiological settings in which the problem is occurring, especially so in the cases of lung parenchyma. Talking about the infectious causes, the most common is the bacterial pneumonia, and it is seen in the clinical setting of neutropenia after chemotherapy or in early post-stem cell transplant cases, as we mentioned here, and the CT chest shows a consolidation. So this way, in this setting and with this radiological appearance, we can, and the clinical presentation, we can tell that the patient may be having a bacterial pneumonia. Then the other common pneumonias could be due to fungus, pneumocystis, or virus. In fungus pneumonia, the setting is almost similar to the bacterial pneumonias. It can occur, like the Aspergillus pneumonia can occur in the early chemotherapy phase, or it can also occur in the early post-transplant phase, or even in the late post-transplant phase. And the CT scan shows a classical halo sign in the angio-invasive aspergillosis, which is a consolidation followed by a ground glassing around the consolidation, or a reverse halo sign, as can be, or the Atoll sign that can be seen in mucormycosis, where there's a donut of consolidation on the ground around an area of ground glassing. In pneumocystis, the patient presents with fever, dry cough, or dyspnea, and or the patient may be having very few chest signs. It is seen mostly in cases of stem cell transplant if the patient is not having any prophylaxis in the late phases of the transplant. And the CT chest, as shown here, the coronal view of the CT chest, shows bilateral perihilar ground glass opacities. The patient may even be having cavitary lesions, pneumothorax that we need to be careful about. And if we have clinical concern for the pneumocystis depending upon the settings and there's no findings in the X-rays, better to get a CT chest. Then CMV pneumonia that can occur in the late phases of the transplant and the patient presents with ground glass changes, micronodules and consolidation in the CT chest as being shown here. We're coming to non-infectious complications. So the common non-infectious complications that can occur in most of the patients are hemorrhage and edema. And we differentiate this based upon the clinical settings and the radiological settings. The patient comes with low platelets, sudden dyspnea, and hemoptysis. And the X-rays showing bilateral alveolar opacities, and CT scan is bilateral ground glassing with rapid progression of infiltrates. We suspect a DH that is confirmed by progressively bloodier bile returns in bronchoscopy. In pulmonary edema, you get a clinical scenario of fluid overload, cardiotoxic drugs, and renal failure. X-ray showing features of pulmonary edema, and the CT chest showing perihilar opacities with some amount of cardiomegaly and bilateral pleural effusion. That gives us a clue that the patient will be having pulmonary edema. The other non-infectious complications could be secondary to the drugs, which can present similar to edema or hemorrhage, but the history of drug intake, drug therapy gives us a clue to the underlying diagnosis. As it happens in the differentiation syndrome, secondary to retinoids for acute promyelocytic leukemia, which can present similar to diffuse alveolar hemorrhage or edema, but the history of retinoid before the presentation gives us a clue to the diagnosis. It's important to know the diagnosis to guide the underlying treatment. As in this case, we can stop the drug and start steroids for a better outcome. Similarly, in the patient who has got an imatinib therapy, which is a tyrosine kinase inhibitor, the patient can present with changes of interstitial pneumonia with features of patchy ground glass opacities along the bronchovascular bundle, and it mimics non-specific organizing pneumonia. So if we have this history, we can stop the drugs and add steroids to get a good response from the patient. This is why clinical settings and radiology settings are essential in giving us a clue about the diagnosis. Now coming to lung infiltrates, which are also very important to understand in patients with hematological malignancies. The common lung infiltrates are either due to infection or due to non-infectious complications like leukostasis, and they are leukostasis or lysis pneumopathies or leukemic infiltration. Leukostasis is seen in patients with hyperleukocytosis due to sludging of the blast cells inside the pulmonary vasculature or the vasculature of the CNS or the kidneys, and the symptoms are due to hyperviscosity and occlusion of the blood flow to the organ. And once you treat these patients, they can go into acute lysis pneumopathy, in which there is lysis of the tumor cells and the patient presents like diffuse alveolar damage. So leukostasis is seen in periods before the chemotherapy, and once the chemotherapy has been started and the patient deteriorates in that period, and which corresponds to onset of neutropenia, the patient may be having, especially so in patients with hyperleukocytosis, the patient may be having a diffuse alveolar damage, acute lysis pneumopathy. And the CT chest shows bilateral multilobar pneumonitis changes. This is a patient of how a patient of leukostasis may be appearing radiologically, although the changes may be non-specific, and a patient of acute lysis pneumopathy may be having multilobar pneumonitis-like changes post initiation of the chemotherapy. Leukemic infiltration is a type of infiltration that can be seen in all the patients, either it's AML or ALL. And here the changes generally occur before chemotherapy, and the CT scan shows peri-bronchovascular infiltrates along the bronchovascular and the lymphatic bundles in the inside in the CT scan, as it's been shown here in this nodular-like change in the CT chest picture. Pulmonary alveolar proteinosis can also be seen in the lymphoid in the hematological malignancies, although it's more common in autoimmune conditions. And the patient presents with fever and dyspnea after chemotherapy with bilateral perihilar alveolar opacities. It is due to the accumulation of surfactant inside the alveoli. Patient presenting with bilateral ground glassing in the CT chest with interlobular septal thickening, a pattern that is known as a crazy paving pattern because of the thickening of the interlobular septa as being shown here. The treatment is whole lung lavage, bronchoscopically bilaterally, and that is pathognomonic most important thing for the diagnosis. Then the bowel fluid that comes is PEA stain positive. We get a whole lung lavage, and this is the treatment, and this makes the underlying diagnosis clear. Now coming to the hematopoietic stem cell transplantation, in this also we can have infectious complications and non-infectious complications, which are categorized according to the phase of transplantation. The early transplant phase, that is the 0 to 30 days, that is the pre-engraftment phase, and then the late transplant phase, that is again early and late. This is post-engraftment phase up to 100 days, and late phase up to more than 100 days. In bacterial infections, in the earlier phases, we see gram-positive or gram-negative infections, and in the later phases, encapsulated bacteria or opportunistic infections like nocardia are common because of impaired cell-mediated immunity. In the viral infections, herpes simplex is more common in early phase, and cytomegalovirus is more common in the late phases, and community-acquired respiratory viruses can be seen in both the phases. And regarding fungal infections, Candida and Aspergillus in early phase, and in the late phases, pneumocystis is more common, and Aspergillus can also be seen. Pneumocystis more so if the patient is not on any prophylaxis for pneumocystis infection. Now, similarly, we can have non-infectious complications in this phase, in the pre-engraftment, post-engraftment, and the late phase. In the early phase, it is due to neutropenia and barrier breakdown. The patient can have peri-engraftment respiratory distress syndrome. In the phase 2, there could be a delayed pulmonary toxicity because of the drugs that the patient is receiving, or an idiopathic pneumonia syndrome, which is a diagnosis of exclusion that we'll see later on. And finally, in the last phase, it could be a pulmonary veno-occlusive disease because of the proliferation of endothelium inside the venules, or a proliferation of the epithelium of inside the bronchus, leading to bronchiolitis obliterans syndrome. Or it could be a post-tumor lymphoproliferative disorder. And in both the phases, there will be some overlap because of the hemorrhage or because of the cytotic thrombi from the PCT that can happen in both the phases. And we'll discuss some of these entities in the next slide. As far as the peri-engraftment syndrome is considered, it is seen in the early phase of the transplant, more so when the neutropenia is recovering. So it's important to know that once the neutropenia starts recovering, we need to monitor the patients carefully, because the patient will be going into worsening respiratory failure. That is known as a PERTS. Patient presents with signs of diffuse capillary leakage in this phase with fever and rash. It's also known as a phase of acute graft versus host disease, the GVHD. This patient generally these patients have a good prognosis with spontaneous resolution. Some patients require invasive ventilation. They show good response to steroids. So identifying this entity, the PERTS during neutropenia recovery, if you're careful about the diagnosis, we can manage the patients well with steroids and, if required, invasive ventilation. IPS, the idiopathic pneumonia syndrome, is a diagnosis of exclusion. Patient is not recovering to the antibiotics and the antifungals, and in the second phase of the transplant, it presents fever, cough, and tachypnea, and has three things: a widespread alveolar injury, no signs of infection, no cardiac fluid. Then we make this diagnosis. It generally has a poor prognosis. The response to steroids is also poor, and most of the patients require invasive mechanical ventilation. PVOD is seen due to the obstruction of the level of venues in pulmonary hypertension. Again, the patients have poor prognosis. Most of them may require lung transplant. Pulmonary cytotic thrombi can be seen in any phase because of endothelial injury and intravascular thromboemboli. The patient has an intravascular thromboemboli and with fever and chest pain. An important DDs for such patients is an invasive fungal infection, and the treatment is immunosuppression. BOOP, or that is a bronchiolitis obliterans syndrome with organizing pneumonia, or the bronchitis BOS, that is the bronchiolitis obliterans syndrome. They are manifestations of chronic graft versus host disease. Patients present with either changes of organizing pneumonia or bronchitis obliterans by fever, dry cough, and dyspnea. They are diagnosed by spirometry. It's important to know that the response of BOS is not good. These patients have a poor prognosis. They present with signs of airway obstruction. And while patients with BOOP, that is organizing pneumonia, have good prognosis, better prognosis as compared to BOS, and they are steroid responsive. So if we have a patient of organizing pneumonia and the response to presence with consolidation, not responding to antibiotics, antifungals, or the ground glassy changes. We can start steroids in these patients. In this phase of the that late phase of the patients may be improving the therapy. There's a case of BOS where we can see the mucosal hypertrophy leading to AV obstruction, and the CT scan we can see focal areas of air trapping and hyperglucency. This is a case of PERS, which is similar to ARDS with bilateral opacities, and there's a patient of PCT presenting with features of intravascular thromboemboli. You can see peripheral nodules and some amount of, like it's shown by the arrow, and some amount of pleural effusion in these cases. Now, how do we approach such patients? This is important to have a good approach, a meticulous approach to institute timely treatment, because undetermined etiology leads to high mortality in such cases. And for this, an approach is important, which is based on a clinical assessment on the history of the patient, time since presentation, and underlying treatment. It's a case of hematological malignancy, what therapy he has received, the time of that therapy to correlate with the underlying problem, the type of immunosuppression, whether it is a B cell defect or a T cell defect or a neutropenia, then the clinical presentation and the radiological presentation. So with the clinical and radiological presentation, we make a pattern and try to fit it into the diagnosis. Then there's a mnemonic known as a direct strategy. It's like a checklist, which helps us to guide the underlying tests for this problem. It's like a pre-test clinical probability. So this is a problem, and these tests we can send in the patient. And then there's a diagnostic panel. One is a basic panel. One panel is a basic that all patients of immunocompromised need to have this panel in the patient. So we go through this panel, and then an invasive panel, that is bronch and the biopsy, to which specific patients need to undergo these tests. The direct mnemonic, D stands for duration of the symptoms, the time specific, time since presentation, and treatment specific. What is the treatment that the patient is undergoing, the type of immunosuppression. R stands for the X-ray pattern. E stands for the experience of the clinician. C, the clinical findings, and T, is very important, the CT chest, because it gives us a positive diagnostic orientation depending upon underlying CT chest changes, which can give us a good orientation towards the test that we need to send in these patients, that we'll see in the subsequent slides. So as discussed, it's like fitting the things into the puzzle. There's an assessment, lab, and radiology pattern that needs to be fit together to make an underlying diagnosis. So teamwork is very important. A collaboration with microbiologists and the radiologists and the hematologists is all important to make a good diagnosis and timely diagnosis. So this is a slide showing on the x-axis diagnosis of a hematological malignancy, AML in this case, time since diagnosis, the earliest phase up to 2 days, then the early phase, intermediate phase, and the consolidation phase with respect to the treatment that the patient is receiving. This is a pre-treatment phase up to 1 to 2 days that in this example, and the treatment phase, which is again divided into early, intermediate, and consolidation as mentioned. So, and now on the y-axis, we have most common, second most common, and third most common diagnosis. This guides us that the patient is presenting to us in which phase of the disease, which phase of the treatment to make an underlying differential diagnosis, the most probable diagnosis. Infections, fluid overload, and edema and hemorrhage can be seen in any phase. So this is the DD that we can keep in almost all the patients as a basic panel of DDs, apart from specific DDs. Like the patient comes to us in the pre-treatment phase, the most common diagnosis in the patient of AML needs to be leukemic infiltration, followed by leukostasis, and thirdly, alveolar proteinosis, if it is a CML. This is a sequence of diagnoses that we can keep in our patients and then look upon each of these. If the treatment has been started and the patient comes in the early phase, then it could be lysis pneumopathy, as I mentioned. After starting chemotherapy, the cell supplies and the patient presents with bilateral pneumonitis. And if the patient is on drugs and cytarabine or drug-related infiltrates, day 4 of the therapy, or cardiogenic edema, then in the intermediate phase, infections start to come up because of neutropenia that starts to now set in the patient, like fungal infection, or in MDS patients, a parainfluenza. On late phase, the patient generally, we get a call for such patients for septic shock and ARDS, or a TB, tuberculosis flare-up in such patients. Because of the chemotherapy, the neutropenia, and the secondary infectious complications I said in this space, or it could be neutropenia recovery leading to an entity similar to PERTS, and patient presents with ARDS. And regarding the type of suppression, patient is on acute leukemia, is acute leukemia, and on chemotherapy, they have neutropenia, and the underlying infections are bacterial infections, gram-negative bacilli, gram-positive foci that we need to treat in our patients. Similarly, T-cell leukemias and T-cell lymphomas, and or the patient is on monoclonal antibodies or drugs like MMF, methotrexate, maybe T-cell defect, and we treat for infections like viruses, mycobacteria, opportunistic infections like pneumocystis, Nepardia, and Cryptococcus. If B-cell lymphoma is the patient is steroids or rituximab, there's B-cell defect, and the patient needs to be treated for encapsulated bacteria, apart from other like mycoplasma, enteroviruses, and viruses and the parasites. This is again the time frame regarding transplant that we have discussed: early peri-engraftment, early and late post-transplantation. We can have non-infectious and infectious complications. Now, the radiological pattern that I was talking to earlier, the patient can have several patterns like the ground glass opacities because of pneumocystis, viral, or atypical. So we think of these three things. If it is a consolidation, we talk about bacterial. We think about bacterial and fungal infections and send respective workups. Nodular, again, bacterial, fungal, opportunistic infections like nocardia, septal thickening only, atypical infections with bacteria. Cavities, as we commonly see, Staph aureus pneumonia, tuberculosis, and histoplasma. Similarly, with pleural effusions, it could be a pneumonia, tuberculosis, or multinodules could be bacteria, virus, and TB. A basic panel for all patients start from nasopharynx, respiratory virus, multiplex PCR, sputum cultures, bacteria, tuberculosis, fungus, aspergillus, pneumocystis, do a GMCR stain, and PCR and immunofluorescence, urine, sen, and degenuria panel for Legionella, Streptococcus, histoplasma, bacteriology, and cytology panels. Blood, sen basic labs, basic panel of labs, blood cultures, serology for atypical bacteria, fungus using biomarkers like beta-glucan, galactomannan, and PCR for mucorales, virus, PCR panel, CMV antigen, biomarkers to plot cardiac failure, and in radiology do X-ray, CD chest with thin sections, and echo and ultrasound to rule out cardiac and causes for other lung consolidation changes in your patient. Invasive tests are not commonly used nowadays because of risk of bleeding and instability. Patients are already hypoxemic. They are generally done if the non-invasive tests that we discussed are inconclusive or for specific causes like diffuse alveolar hemorrhage, PCP, pneumonia, or drug-related toxicity. Now, safety is better with NIV and HFNC if it's used together, but generally nowadays the trend is toward non-invasive tests. Biopsy, again, the risk is similar to bronch. In retrospective studies with undifferentiated etiology, it was found that fungal infections and steroid-responsive chemotherapies were found in many patients. So this could be one of the role if the patient is not improving and you want to diagnose the etiology, then biopsy can be done. Most of the studies found that although at retrospective, fungal infections and steroid-responsive chemotherapy in such cases. Coming to management strategy depends upon underlying etiology management and oxygenation and ventilation strategies. Most of the guidelines, we have different devices, as we all know. Most of the guidelines give an IV as first-line therapy for acute hypoxemic respiratory failure. But the evidence is weak as it is based mainly on observational studies and only 2 small randomized controlled trials. The first randomized trial was done in 2001 by Hilbert and co-workers in hematological malignancy patients, and in which they compared NIV with oxygen diventory mask and looked for need for ventricular intubation and IMV. They found that the need for ventricular intubation and IMV was significantly reduced in patients on NIV. But if we see, it was a very small study of 50 patients only and a single center study. So it's difficult to draw a conclusion based on this study. And subsequent studies, the observational studies and the two randomized trials, one of them having around 370 patients, found that lots of discrepancy in the benefits of NIV. Failure rate as high as 70% and mortality as high as 90% after the NIV. So what is the evidence base for NIV? Should we use it in all patients or should we not? So looking at the randomized trials, the largest trial done in multicentric medicine ICUs in France, including hematological malignancy patients, which showed no difference, has certain limitations like the control arm in which the oxygenation methods and were at the clinical discretion, and there was HFNC usage in the control arm. Moreover, it was an underpowered study, and in another randomized controlled trial, which is not so big, there was a crossover. So it's difficult to negate the role of NIV, being the underpowered nature of the studies, the crossover between the arms, the HFNC used in control group, lower PEEP setting of the NIV group as compared to the trial by Hilbert, the short duration of NIV in hypoxemic failures as compared to earliest the Hilbert trial. It's difficult to say that's not beneficial. So what do we do? What are the candidates suitable for NIV? So in a retrospective study looking for the predictors of NIV failure in hematological malignancy and ARF, which studied patients who were 10-year period, they found that the independent predictors of failure were respiratory rate and the NIV, delay from ICU admission, and more so the need for vasopressin and RT, that is severity of the underlying illness, and the severity of ARDS were having very high odds ratio for failure. And they concluded that NIV failure was associated with high mortality, and the predictors of failure may be used to guide intubation in such patients. In other similar studies, a sub-study from the lung safe study looking for the use of NIV, role of the utility of NIV in ARDS, found that hospital mortality was high in NIV failure, and patients with higher ICU mortality had a lower PF less than 150. In a post-hoc analysis of thoraly RCT looking for predictors of intubation in patients with hypoxemic respiratory failure, they found that besides respiratory rate and heart rate at 1 hour of the therapy, they found that in patients with NIV, tidal volume more than 9 ml per kg at first hour of therapy and PF less than 4 had a high odds ratio for intubation. So they also found that a high tidal volume can be harmful for the patient, as we are now seeing patients with spontaneous self-inflicted lung injury in patients with COVID. So this tidal volume of more than 9 ml per ml can be detrimental for the patients. In a few years back, HECOR score was proposed, although it's not validated, to look for patients who are at early risk for NIV failure based on heart rate, acidosis, consciousness, PF ratio, and the respiratory rate. And they found that HECOR more than 5 after 1 hour of NIV would predict NIV failure in our patients. Now coming to HFNC, it's having an emerging role because of its physiological benefits inherent to high flows, high FiO2s, warm and humidified gas, dead space CO2 washout, and some amount of PEEP with closed mouth. So can this translate to mortality benefit and low risk of infections in our patients and low intubation rate? The randomized trial that came up recently looking for the efficacy of HFNC versus oxygen on 28-day mortality, in which they recruited patients with hypoxemia, labored breathing, and on oxygen of more than 6 liters per minute. They didn't find any mortality benefit, although the risk of intubation and nosocomial infections were not different. And but they found that the patient's respiratory rate was significantly lower after 6 hours, and the PF was significantly higher until day 4 in these patients as compared to oxygen. And the findings were similar to post-hoc analysis of 2 randomized trials also. In a meta-analysis that came up recently looking for the effect of HFNC in such patients, it was found that HFNC may have some benefit as compared to NIV or by having lower intubation rates, and the nosocomial infections were also not increased, but there was no mortality benefit, and they concluded that high quality RCTs are still needed to confirm the findings. So what determines the outcome? Is it the strategy of ventilation? Or is it something else, as we see in our common ICU patients, so general patients, the etiology, the ICU admission time, or severity of illness. So the studies that have come up in this area focusing on high mortality and the risk factors found that etiology, the severity of illness, NIV failure, more so the unidentified etiology as high risk factors. And they also found that the pattern of etiology, the changes in the radiology, diffuse changes or the GGOs or the micronodular changes are also important to look at the outcome of the patients and guide the management. This is a study showing delayed ICU admission and mortality. The mortality was more in patients with delayed ICU admission. A recent large prospective study that came up in 2017 found that NIV failure, the oxygen failure, and HFNC failure had high mortality, as been found in other studies also, besides an undetermined ARF etiology being an additional predictor of mortality. Regarding the non-invasive strategies of oxygenation, the recent meta-analysis has not shown any difference in terms of mortality, although NIV may be better than oxygen as far as intubation rate is considered. But as I said, there's no mortality benefit with the initial strategy of oxygenation. Now, what is the trend in survival with the ventilation? Now, initially feared as all patients requiring ventilation die, but what is the trend? How has that changed? So the recent study that came up in 2021, 11,000 patients, in which they included patients from the systematic reviews and meta-analysis done on immunocompromised patients. And where they were looking at the trend of survival over time with invasive ventilation and the impact of delayed intubation on the survival. Around 70% were intubated in 24 hours of intubation, and they found that early intubation was significantly associated with lower mortality as compared to the earlier thought process that IMV is always dangerous. They found that unlike that, patients had high survival, lower mortality. And they concluded that survival has improved over time, and time between ICU admission and intubation is a strong predictor of mortality and suggesting a detrimental effect of late initial oxygen failure. So is it the time to think differently in terms of invasive mechanical ventilation? So in the last 20 years, what from being an IV in all patients and IMV no, in none, it is now time to individualize an IV based on disease severity so far, the timing of the disease, the timing of admission, the predictors of an IV failure, what is the response to therapy, close monitoring of the vitals, and also the tidal volume should be less than 9 ml per kg. And the standard of care ICU is improving in general. The mortality of patients with IMV, as we have seen, is coming down. It's also important to look at the etiology, ICU admission, and give an early organ support for a better outcome. Regarding HFNC, it is still in the emerging phase. So from no, avoid IMV, the bottom line is do not delay IMV when indicated. We look at the contraindications of NIV and monitor for the success or the risk factors of failure in terms of reduction in respiratory rate, the improvement in pH, oxygenation, and PCO2, and keep IMV ready bedside. And if there's any contraindication to IMV or is high risk of failure, we go for straight away with IMV without delaying IMV anymore. And if the patient is less sick and there's less risk of failure, we can initiate IMV and monitor closely with clinical status monitoring, ABGs bedside, and the patient is not showing any improvement, we go for IMV. The bottom line is we do not delay IMV, keep a close watch on an IV in suitable candidates and subsequently decide our therapy. Coming to specific ventilatory strategies, besides the management of underlying etiology, we need to see what is the pattern of disease and institute the ventilatory management accordingly. It's important to address difficult airway mediastinal masses, pneumothorax, large effusions also in our patients, because if we miss a pneumothorax and intubate, the patient is anyway going to crash. B, focus on infection control issues. Difficult airway card should be ready, and ANT should always be on alert because there will be tumor mass inside the airway. Keep our intubation checklist ready for a smooth process of intubation. Now, specific ventilatory strategies could be a restrictive pathology because of ARDS, trolley, hemorrhage, or ILD-like changes post-central transplant. Obstructive pathology because of bronchiolitis obliterans syndrome, or a BOS with the organizing pneumonia, RB dysfunction because of embolism, metabolic acidosis because of shock, bleeding because of ETD, diffuse alveolar hemorrhage, and ICH. And once weaning, the patient may have weaning difficulties because of it could be tracheoesophageal fistula or cardiac etiology or a neuromuscular weakness. And if they always look for dope pneumonic venous crisis like displacement of the tube, obstruction of the tube, pneumothorax, and equipment failure. And be careful about the adjunctive care like humidification, bronchodilator therapy, ED suctioning, and daily weaning protocol in your patients. And always remember that it's a double-edged sword. They can also be some benefits and some harms. So we need to weigh in the benefits and the harms carefully in our patients time to time. ARDS, as well as heterogeneous disease, is a normal lung, that is a baby lung with small volume. And then there is an intermediate phase, a heterogeneous phase, and then a consolidated phase. So this is the phase, the lung that we are trying to protect by doing a lung protective ventilation. And then there's an area of sandwiched between the normal lung and the consolidated lung that is prone to repeated opening and closing of alveoli. So we are trying to prevent atelectoma by giving some amount of PEEP to this lung. The strategy is lung protective ventilation, up to 6 ml per kg tidal, predictive body weight, predicted body weight, keep PEEP at less than 30 to avoid damage to the baby lung. Driving pressure, again, normalizing is a concept to protect the healthy lung, keep it less than 15. We don't want high oxygen in our patient. We even don't want low oxygens, so keep it between 55 to 80. Give an optimal PEEP to the patient. That's different strategies to set it at the bedside. And prone ventilation, as we have done in COVID patients, we have seen its benefit in moderate to severe ARDS. Same as the concept in patients with acute respiratory failure and immunocompromised in moderate to severe ARDS. Prone ventilation can be given if required. Coming to bronchitis obstructive syndrome, we ventilate it like an obstructive air pathology. We prevent air trapping and increase the expiratory time in such patients to minimize the hyperinflation and the secondary lung injuries. The target is again to keep CO2 such that the pH is above 7.2. We don't want normal PCO2. We want permissive hypercapnia because we don't want to give more rates, more tidal volume, and decrease the time for expiration. This is an example of setting in a patient 680 ml per kg tidal volume, keep low rates, keep high inspiratory flows, so the inspiration is shortened and expiration is prolonged, and there's minimal air trapping. The patient may be having ICH secondary to thrombocytopenia. So the goal is to protect the lungs from secondary injuries. Don't allow ICP to increase, keep the pressures normal. Don't allow CO2 to increase so that the blood flow doesn't increase, and monitor ICP in your patients if there's an ICP monitoring device, or be clinically careful about the neurological status. Then severe metabolic acidemia. One thing is very important, that these patients, the CO2 can just rise even during brief period of apnea. So if you paralyze the patient, so suppose the patient is hyperventilating and you paralyze him, the CO2 just rises and the drop pH crashes drastically. So it's important that avoid paralysis in your patients. Even brief apnea may lead to life-threatening acidosis. So you have focus first before intubating, see the underlying cause that can be managed. If it can be managed, focus on that cause. It could be sepsis and lactic acidosis, it could be renal acidosis, start RRT, you may give oxygen NIV, and if this is improving, you may even need not to intubate the patient. But if the patient is crashing, you need to intubate, but be careful that you give small amount of sedation and just intubate. Don't give large amount of paralysis. Even if you're paralyzing because patient fighting and not synchronizing, try to give high minute ventilation as close to the patient's spontaneous ventilation. So CO2 gets washed out in your patient. Then there could be an RV failure secondary to pulmonary embolism and RV dysfunction. Be careful of RV size and RV preload and afterload. Don't overload the patients, more so in patients with chronic RV dysfunction. But like in pulmonary veno-occlusive disease, but it's an acute embolus, they have some margin for fluids. So be careful, do an echo, assess the RV size and give fluids. So the strategy is to optimize fluid board balance, reduce RV afterload, optimize the cardiac peak output, and optimize the perfusion pressure. Finally, while extubation, assesses by the patient by a spontaneous breathing trial, the patient is improving, lung disease is improving, hemodynamically better, and able to protect the airway. An SBT can be given to assess the safety of extubation. And weaning is also considered as a hemodynamic stress test because most of the patients crash during weaning because the inherent cardiac abnormalities start to manifest. Take-home points are: focus on the etiology, don't persist with NIV in patients not improving, and look for patients at risk of NIV failure and go for early intubation such patients. There's no guidance scoring system. Be carefully at the bedside and do a bedside monitoring carefully, and be careful about the specific ventilation.